Welcome back to Medical Monday, talking with Dr. Madhu Elameli with the Nashville Pain and Wellness Center about chronic pain, something that affects so many people. We already have several calls, so let's go to the phones. Let's go to Jerry on line one. Hello, Jerry.
Yes.
Hi, what's on your mind?
Yeah. In 2012, I had a total knee replacement.
Okay.
Okay.
And even before that, my knee was hurting on the outside of my knee, but it wasn't like in the joint mostly. But it's
Okay.
every day since then, I hadn't been able to get up and get around on it good. When I sit down, it hurts, and when I walk on it hurts. It's on rough terrain and stuff. And I also do construction work.
Oh.
How old are you?
61.
61. Okay.
And still working with this pain?
Yes.
Oh, that's very really commendable. I mean, see, this is a very good question you have asked, Jerry. Chronic pain. This is a good definition of chronic pain. You have had surgery. You had knee problems. You had probably end-stage osteoarthritis of the knee. So that's why you underwent knee replacement, isn't it?
He may not still be there, but is that? I probably.
Okay.
Let's
so
say it is.
so a lot of patients continue to have pain after such a surgery. It is not that the surgery has not helped. Surgery would have helped the patient with the pain, with the problem in the knee. The person would be now able to walk, but there is still pain. That doesn't mean in any way that the surgery was not needed or the surgery was not successful. The surgery has done its part. There's a major part of the problem here is that probably he was not even able to walk before the surgery was done. Probably the knee was swelling up all the time, but now he's able to walk, he's able to take care of most of the stuff, but the pain is still there. So now we come into the picture to try to manage this pain. Now try to find out what the problem is. Why is there pain? Once there is just metal in the knee, there's nothing else. See, we should remember that there are other tissues around the knee joint. There are muscles, there are tendons, there are ligaments. All these can cause pain. Many times when you have a surgery, the small nerve endings in the tissues around the joint get damaged, and it causes neuropathy. I have seen patients who have compressed nerves, pinched nerves in the back at certain levels that can refer to the knee. In fact, the pain may be coming from the back too. So we always look at a patient who continues to complain of knee pain after knee replacement. We always look at the back. We take an MRI of the back and see, is something going wrong there? Is that causing the pain in the knee? And many times we have found that there is a compressed nerve in the back that is also causing part of the problem. So we try to address that. We try to address the compressed nerve in the back. Or we try to find the cause of pain around the knee joint itself. And nowadays we have also started blocking the nerves that supply the knee joint. And see, these nerves had a big role to play when there was a real knee joint before. Now the knee joint is gone. There is only metal. We don't need all these nerves going into the joint just firing up all the time. So sometimes we block these nerves. This is something new. It's not done on a regular basis, but of late pain physicians have found very good results by just ablating the little nerves that supply the knee joint, that used to supply the knee joint in the
And
past.
how do you do that? So how do you stop those nerves or deal with those nerves? How is that done?
So first we do just block it with local anesthetic and a little bit of steroid if needed. We just block these nerves and see if that takes the pain away. It's diagnostic. The pain relief may not last a long time. It may just last a few hours, maybe a couple of days, or maybe a week at the maximum. But if it does go away, if the pain does get better when we block these nerves, that's a good indication that these nerves are causing the problem. Or the tissues around the knees, around the knee joint, the tissues are causing the pain. So when we block these nerves, the pain goes away. Then what we do is we use radio frequency waves, which actually raise the temperature around the nerve from anywhere from 42 degrees to 80 degrees, depending upon what we choose. And we just ablate these nerves. These nerves are not doing anything except feel the pain in the knee. So when we ablate these nerves, patients get prolonged relief for several months to a year, and it takes just a few minutes to repeat it whenever the pain comes back. So there are several ways we can manage this pain. So this is just a good example of how pain management can get into the mix and try to help these patients.
And this is not surgery, right?
No, this is all done. Most of these procedures that we do are done in the office, are in the hospital or a surgery center, and they're all vast majority of them are same day procedures. Like they just come to the clinic and get it done and go home within minutes, with maybe after 30 minutes of, if they get sedation, they IV sedation. We just watch them for 15 to 20 minutes, and then once they feel better, we just send them home. So
somebody like Jerry, if he, and I bet that's a fairly common one, knee pain.
Mm-hmm.
The first thing, so if somebody like that comes in and says, I had surgery and I still have pain, what's the first thing you generally do? Is it the MRI, or kind of what's the first thing you would do?
First thing I would do is, as I said, first thing is examination.
Right.
Examination. That's very, very important in pain management. We don't rely on imaging studies as much as we rely on examination. So once we know the examination findings, then we try to correlate them with the imaging studies and with other tests. I may get a nerve condition test done for him to see if there is a neuropathy around the knee, or I may get a nerve condition study to see if there is a pinched nerve in the back, or I may do an MRI of the spine. Depends on what I see during the physical examination. If I feel during the physical examination that all the pain is coming from the tissues around the knee joint itself, I may just start treating him with topical ointments or topical creams, or I can just start him on some pain medications initially while we are trying to find out what is going on, and then come up with some procedures that can help him in the longer run.
Jerry, thank you. Thank you for that call. Thank you for sharing that. Let's go to Donnie on line 2. Hello, Donnie.
Good evening.
Hi, what's on your mind?
I got a couple questions. I've had my spine 35 years ago got messed up, and I've had pain since then. I've had medicine for it and tried the injections. None of it works. I got a machine at a chiropractor thing in Nashville somewhere, but it cost $6,000 almost to take care of it, straighten it out. But I had a bad fall about 2 months ago, and I bruised my brain, they said. Is there anything he can do about that? And I'll hang up and listen.
Wow. All right. Thank you, Donnie, for sharing that. I'm sorry you're going through that.
Oh, I'm sorry too. Sorry you had to spend all that money and now the pain is back. He said he smashed his something. I didn't get that long.
It's his back. It's
okay.
Back pain.
No, the back pain. So again, this is the kind of situation where the pain needs to be managed. So he has had medications, he has had injections. So we may have to again go back to the drawing board and see, go to the imaging studies, examine him again. So this we have to do on a continuing basis. In a patient like him, who has had 35 years of pain and has had back surgeries, who has already tried everything, this becomes more complicated. So we have to talk to these patients, see these patients more often, patients like him. Every time something happens, an event happens where the pain gets exacerbated, we call it acute flare-ups of the chronic pain, then we have to be there to figure out what happened now. Where is the pain coming from now? It was okay, it was earlier, probably it was coming from somewhere else, now it may be some other place the pain is coming from. So every time we do a targeted injection, it depends on the physical examination. So it is not that he had pain once and we all decided that it's coming from a so-and-so structure and we keep targeting the same structure again and again and again every time the pain comes back. No, we have to have an open mind. We have to look again, we have to just start all over again and see where the pain is coming from and try to help.
He mentioned a treatment. He said $6,000. Is that uncommon? And money is such a big issue.
Yes.
For so many people, obviously. Let's broach that subject. I mean, are you aware of the treatment he's talking about? Is that uncommon to spend that kind of money?
No, it is very common. I mean, we know there is, I think what he's talking about is a lumbar traction. It's a very complicated instrument. It's an apparatus. It's typically used by chiropractors, and that's what he said. I think he went to chiropractor.
Right.
So they use this machine to put traction on the spine and try to get the disc to go back into place or something like that. So it is very it takes several sessions. I think they go for these sessions several times a week, then several times less and less frequently over a period of several months. I think I'm not very clear about how. I mean, it all depends on each chiropractor how they manage this. So it's not something we do. So I shouldn't be talking too much about it. But yes, I have seen patients who do feel better after this. But again, this is a one-time treatment for $6,000, and then if the pain comes back, again having that done, it's going to be very difficult.
It's not an ongoing management.
Right.
All right, we have to take a break. We have several calls. If you want to call, there's the number, 737-PLUS, 737-7587. We'll take a break. Be back right after this.